So next we're going to talk about preventing the respiratory complications of immobility. Atelectasis is generally the beginning of this, and then it can move into pneumonia because those secretions that are sitting still start to grow bugs. So to prevent atelectasis, again, reposition that patient. To get the best lung expansion, we want the patient walking if they can, standing if they can't walk, sitting if they can't stand, moving in the bed if they can't sit. Okay, if we can get them out of the bed, it's better. If we can get them walking, it's better. And I'm seeing more facilities have PT come in early to work with patients to get them up and moving, and it prevents a lot of these complications. So we want to reposition that patient at least every 2 hours if they can't, if that's the best we can do. We want to ambulate them early and often. Turn, cough, and deep breathe every 2 hours. I don't see people do this much anymore, but if your patient can't move around, you want to have them changing position, taking some deep breaths, cascade coughing every 2 hours. We also have incentive spirometers. Those are a handy little device that encourage the patient to take deep breaths. It gives them a goal. An incentive spirometer works best if the patient inhales slowly to move the large marker up to their goal, while maintaining, usually there's a smaller marker that you want to show that it's showing you're inhaling slowly. So rather than, we want to see, okay? And you'll see on your incentive spirometer, if you don't know how to measure it, get a respiratory therapist to show you. But on your incentive spirometer, you'll see how to measure both of those things. What's that patient's target? But also, you want to, it's like, teach them it's like a game. You want to keep the marker for how quickly they're inspiring. You want to keep that to showing that they're taking a slow, deep breath. If your patient is showing signs of atelectasis, have them use the incentive spirometer 10 times every hour. And it makes a difference. We also want to make sure that the patient is getting adequate fluid intake. Getting enough fluid in helps make sure those secretions don't get thick and sticky, or it helps thin and loosen up the secretions. If atelectasis develops, an aggressive pulmonary hygiene may prevent pneumonia. Okay, that's using their incentive spirometer every hour, getting them moving every hour. Chest physiotherapy, chest PT, is using percussion over the lung fields to try to help break up that mucus that's sitting there. If the patient is not able to bring up secretions, we need to suction them. We shouldn't be routinely suctioning patients. Whenever you put a suction catheter into the patient, whether it's by trach, nasotracheal, or a tracheal, when you put that in, you're introducing potential bacteria. We should be using sterile technique, or at the very least clean technique. There's been some controversy about that, but sterile technique tends to introduce less bacteria. But also you actually can stimulate more mucus production, and you can stimulate a vagal response. So we suction if they have secretions they can't get up, but don't just suction routinely. Patients may be prescribed bronchodilators. So if they're getting bronchodilators, they may be getting bronchodilators and steroids if they have a respiratory condition. If they're getting both inhaled, always give the bronchodilator first, because that opens up the airway so that they absorb the steroids better. In the next section, we're going to talk about cardiovascular complications.